Okay. Welcome everyone to our third annual now Ethics and Professionalism lunchtime session at the ASNC annual meeting. It's really a pleasure to have you here and nice to see such a good turnout. If I can invite everyone to sit further forward, because I hope we can generate some good interactive discussion. My name is Andrew Einstein from Columbia University Irving Medical Center in New York. And I just would like to start off by giving you a brief overview of what we're going to do. We have two terrific case-based presentations prepared. The first one on alleged inappropriate studies in cardiology and nuclear cardiology. The speaker on that topic is going to be Dr. Neil Dickert from Emory University, who is not just a cardiologist but has a PhD in biomedical ethics and conducts research in that area. Our second case is going to be on reducing radiation in the real world. That's the presenter is Dr. Steve Bloom from Kansas City, who's one of the leaders in a 27-person, many-site private practice cardiovascular group, and he's going to talk about how he uses dose reduction techniques to improve the quality of care his patients receive in the real world. In comparison to us academics, he's not sitting in an ivory tower. We're going to have two halves to the program. The first half is dedicated to the inappropriate procedures performed. We're going to have a 10-minute presentation from Neil Dickert, and we're going to have a brief discussion, about 10 minutes, from our esteemed panelists, and then we're going to open the floor for questions from you. We're going to repeat the process for the second presentation, which Steve gives. Our esteemed panelists are Dr. Kim Williams, the immediate past president of the American College of Cardiology, as well as a past president of ASNC, Dr. Bob Hendel, a cardiologist at the University of Miami and the incoming chief of cardiology at Tulane University, and also an ASNC past president who, in his Varani lecture recently, addressed the issue of professionalism in nuclear cardiology, which is something that's so important to ASNC and to the nuclear cardiology profession. And our third expert panelist is Dr. Steve Stowers, formerly from the United States, now from New Zealand, who will provide us undoubtedly with a comparative perspective in terms of drivers of practice patterns in the United States and worldwide. So with that, I'll turn over the session to Dr. Dickert, who's going to talk about alleged inappropriate imaging and intervention in cardiology.
Thanks very much for the nice introduction and for the opportunity to talk with you guys today. So I have no commercial relationships to disclose, just research funding. So my goals really quickly are to highlight a few high-profile cases. I'm not going to focus on what makes them illegal or criminal. These were legal cases, but rather talk a little bit about some of the drivers that I think might be present for inappropriate decision-making, things that we all need to be aware of and that affect patients and us, and we'll generate some discussion about that. And importantly, I'm not going to talk about things like incentive structures or legal concerns that often do get discussed. I want to talk about some of the other things that I think don't get discussed as much. So this is a case some of you may be familiar with, high-profile case, Westlake, Ohio cardiologist convicted of performing unnecessary catheterizations, tests, many of which were nuclear imaging tests, stent insertions, and causing unnecessary coronary artery bypass surgeries as part of a scheme to overbill Medicare and other insurers by $7.2 million, according to law enforcement officials. Right, so there's a way in which, right, this talk's done. You just can't do that, right? So inflated billing, falsified records, which were accused or alleged in this particular case, those obviously are not things that pose ethical dilemmas, right? You don't make up results, you don't make up symptoms. That's sort of not going to be the focus of what we talk about. It's more about some of the decisions that were made with regard to inappropriate procedures, things like PCI of lesions that were non-significant or borderline, yearly nuclear stress tests in a 30-year-old, improper cabbage referral. These are things that were raised in this particular case, and I think help us to start to think a little bit more about some interesting parts of this case. What I found particularly interesting was the physician's response, in the sense in which this was framed as looking out for his patients, right? So this, I think, is a wonderful quote. You have to err on the side of caution. It's often a life or death situation. It's Russian roulette, and I don't want to play with my patients' lives, so I do the procedures. This is another case that is a little different, but also a relatively high-profile case from Florida. Dr. Y collected $18 million from Medicare in 2012, more than 4 times as much as the next highest-paid cardiologist. The lawsuit that was brought claimed that Dr. Y performed possibly thousands of unnecessary procedures and essentially paid patients kickbacks by waiving Medicare copayments to encourage them to approve more medical work. Right? So patients really like that, right? You reduce their payments. That seems like something that's helping them out, right? It's illegal, but it gets to be a little bit more interesting, particularly when you start to learn about patients' perceptions of people who make decisions like this, right? So Dr. Y is the most caring doctor. This is from Health Grades. Most caring doctor I have ever had the pleasure to meet. He's taken care of me when I had no insurance, and I feel he saved my life. Now that I have Medicare only, he takes the same wonderful care he's always taken. If you're looking for a great doctor of cardiology, look no further. I've been seeing him for about 10 years and would never change. Right, so I think this gets a bit more interesting. Obviously, to the extent that these practices were highly problematic, we're going to not focus on ways in which they were or weren't. It's problematic to frame fraudulent practices in the context of patients' interests, right? That obviously violates trust they put in us and ignores the harms of overtesting and intervention. But the lines obviously aren't always clear, and as we know, there's still an appreciable rate of inappropriate use of perfusion imaging and obviously real potential for downstream harm. At a very conceptual level, none of this is difficult, right? The ethical issues are pretty straightforward. You should do the right test at the right time for the right patients, and you should try to engage patients in shared decision-making, particularly when decisions are preference-sensitive. The challenges, I think, that we all know are at the borders of appropriateness, particularly at the borders of kind of lower value and inappropriate, due to forces that I do think it's important that we recognize and address. So I want to talk about 2 of those things and hopefully raise some discussion. So one is we're sort of hardwired to do this badly. So patients and physicians both make decisions in ways that do encourage this idea of erring on the side of caution. And second, there are structural problems related to, as many of us know, fragmentation among providers that can really exacerbate some of these challenges in the context of nuclear cardiology. So I'm going to bring in some insights from the behavioral economics literature, which I think are interesting and appropriate here. So one, there are ways in which our decision-making just gets short-circuited by tools that we use all the time. So one of them is called the representativeness heuristic, right? So Kahneman and Tversky, in really groundbreaking work many years ago, gave people this example. They gave a quote. They said, "Steve is shy and withdrawn, invariably helpful, but with little interest in people or in the world of reality. A meek and tidy soul, he has a need for order and structure and a passion for detail." And then they asked, was Steve a farmer or a librarian? Right? So many people said Steve's a librarian. The problem is there really aren't very many librarians around. So the odds are Steve's a farmer. Right? So this is a problem that we all deal with. Right? In low-risk kinds of situations, we ignore pre-test probabilities, yet they have a really important role in making decisions about appropriateness of testing and procedures. Similarly, the availability heuristic is all about sort of drawing from what you know best, right? We assess the probability of events by the ease with which instances or occurrences can be brought to mind, right? Classic ways in which this comes up is when a patient comes in and said, "Hey, doc, the last person I know who had chest pain wound up with a huge heart attack. I don't want to be like that." Or from a physician's perspective, that lingering case, the last guy you saw with that complaint died of a heart attack a few days later, and it really changes your perspective. But it's a short circuit that we use, right? It's a heuristic that we develop, and we all have it within us designed to try to make decisions quickly. There's lots of ways in which we screw this up, right? And framing matters a lot, both in how we present things to patients and in how we understand them ourselves. This is one of my favorite studies where essentially they gave physicians, patients, and students very different situations, or very different presentations of the same information about their odds of doing okay with radiation versus surgical treatment for lung cancer. And we won't go into the details of the study, but this is basically based on whether or not these were framed as their chances of dying or living with different therapies, look at the difference in the number of people choosing a radiation course versus a surgical course, right? And physicians had as much or more, were as much or more affected than patients were. So I raise these examples only to talk about the fact that we are clearly subject to numerous influences on our decision making, many of which we're often not aware, but certainly can be operative, as I think we can see in these cases, in some of the borderline cases. So the last thing I want to raise is just the sort of snowball of decision making that can happen in the context of ischemic heart disease in particular. One of the things I think is most challenging is that there are often multiple providers involved in this sort of series of decisions. This is something we talked about a couple years ago at the session too. There are different risks and benefits right at each stage from the clinic visit to an intervention. And the decision about the first is clearly affected by the risks and benefits of the last in that stage. But what happens is a lot of times these pass through multiple providers. Different people have different expertise, different kinds of conversations with the patient, and it's really easy to see how that sort of snowball happens. And I think that's an important driver of some of these decisions. Not as much raised by these two cases that we discussed at the beginning, but an important thing for us to be aware of. So obviously trying to combat that at the outset runs a significant risk of profound information overload, both on the physician's part, but particularly from a patient's perspective. It's a lot of things to consider at an initial visit when all you do is come in and say, I've got a little bit of chest pain. So I'll wrap up, but what I've hoped to try to focus on are just the ways in which there are real challenges to ensuring appropriateness that I think are revealed. They're kernels of really difficult problems within some of these pretty extreme cases. I think it's important that we confront fundamental biases and heuristics that affect both us and our patients, and that we think about upstream interventions to address this kind of snowballing challenge with regard to serial decisions and fragmentation of care. And I hope that acknowledging these challenges and carefully framing decisions can advance what I think we'd all agree is our clear ethical duty to reduce inappropriate testing and interventions.
Okay, great. Thank you, Neil. Any first thoughts from the panel? Dr. Williams.
So, are we on? So I'd like to add just a couple of nuances to this whole issue of overutilization. And it's interesting how there's actually three of them that are going on right now. One is, everybody's familiar with Press Ganey. I don't know if everybody has that in their institution. In order to satisfy the Press Ganey, you have to keep the patients very happy. And so you noted that the one cardiologist with the 18 million had glowing remarks by the patients. The patients feel, cared for and loved, and they feel like they're assuming that they're getting the best medicine. And so that's one of the things that our physicians have to deal with, caving in to patient demand, whether they're being measured just by the patients themselves or by this external body. So that's one issue. The other one that has always concerned us, particularly from advocacy, from ACC, ASNC, is defensive imaging. And it's been scored by the Congressional Budget Office, multiple billions of dollars, where a physician will feel like if they don't do this test, and this is sort of like what the first person was saying, Russian roulette, if they don't do this test and there's a bad outcome, even though it's a very low pretest probability that the patient has significant disease and an even less likelihood that the patient is going to die from whatever their symptom is, if you do not do this image, you will be held to a standard because someone will find an expert witness who will say that your care is substandard. So what are the answers to that? Really, my colleague to the right has done a lot in this area with appropriate use criteria. There are guidelines, obviously, that talk about test ordering, but appropriate use criteria and practice guidelines can really inform folks. And what we've always hoped for is that the courts, the panels that will do reviews of lawsuits will actually look at what what the major societies and the experts say about this particular case. And if you are following the guidelines, if you are following the appropriate use criteria and you did not order a test, you should not be held to some legal standard that is set by some community practice as defined by an expert that the plaintiff comes up with. So it's still a vexing problem. We haven't solved that yet. I'm hoping that we get to it.
I think Dr. Williams has made a number of outstanding comments. I just wanted to address a couple of them. First of all, with the whole concept of patient satisfaction, which I agree with, I've been involved in appropriate use criteria development now for 12 years, and it's been quite a journey, both from very unpleasant to almost understood. And even our patients struggle with this, and the reaction that's described where patient satisfaction may be related to performing more tests. My doctor cares for me, he's doing this. I've had a patient who specifically said, the last doctor I had ordered this every time, why are you not doing this? You obviously don't care, I'm going to find someone else. And really what that highlights is the need for a dialogue and for shared decision making, which I think nowadays we're all familiar with the concepts, but we need to move towards the practice of this. With regards to appropriate use criteria, I think the journey has been going one from violent opposition to almost an acceptance of saying it's self-evident, that of course we should be doing this. I think the reality is we still struggle with this, and I think a lot of it is just understanding what they are and having our patients and our communities understand what the purpose is. They're not there and they're not developed for specific individual patients. What they're really there is to help guide us as care providers in what is the rational strategy for a population or a cohort of patients. There are always exceptions, and appropriate use criteria, just like guidelines, were never expected or intended to be substitute for sound clinical judgment. And I would emphasize sound clinical judgment, something based on rational thought. So there's always an exception, and there's always people that we all know, well, gee, this might be deemed rarely appropriate, but in this circumstance, given this patient, this is something that we have to consider doing, and that's fine. But when you as a whole are looked at versus a variety of other people, when we look at benchmarks, if you're performing the kinds of practices that you outlined here today, where the perhaps rarely appropriate rate is about 25 or 50%, and all of your colleagues are doing 5 or 10% to account for that judgment, there's something wrong, and that starts to come through. And the message has really been carried through even to the payer community, that it's not supposed to be an individual patient, but practice patterns are really what needs to be looked at. These are advisory documents. They're not gospel, but I think hopefully we should get the message that we can improve our practice and we can optimize that, and I think that's the principle of ethics.
Dr. Stowers, how are things on the other side of the world?
Well, I have a different perspective in that I was in private practice, I had my own nuclear camera, had unlimited capacity to do nuclear imaging in the office and in the hospital, and patients were hospitalized. But in New Zealand, we do not have unlimited capacity. We have limited capacity, and we're mandated by a national clinical priority access criteria for prioritizing patients for scans. So no one can get a scan unless they meet a certain level of scoring on the clinical priority access criteria score called the CPAC score. And I would think that that might be something that the United States, with this quality for payment for quality and not fee for service anymore, is going to have to move toward, is mandating a national scoring system for clinical priority and appropriateness for testing.
Okay. Why don't we open the floor up to questions? So Dr. Sakara and Dr. Thomas are our moderators on the floor. Go ahead.
This is directed towards the ACC. Does ACC have a clinical decision support tool ready to go to embed in our EMR systems yet?
It's an excellent question. I think documents by themselves are really not that helpful often, and we need to put the tools and the understandings in our fingertips. There's been a number of independently created options. ACC does have a current tool, But moving towards the CMS mandate, now that certainly the ACC ASNC appropriate use criteria have been adopted by CMS as a provider-led entity, and those will constitute legitimate appropriate use criteria as deemed by CMS, the issue of vendor support is coming through, and basically the message is ACC will have a product, but so will other vendors. The key is that they all say essentially the same thing, and how they use and how they're integrated into various EHRs and other domains still is in progress. And even though we now know the timeline, I think the fact that they've adopted a set of AUC is fine, but getting the vendors to have this ready in the next year and a half or so is going to be a really serious challenge. But the tools will be made available or the mandate doesn't go through. In the interim, though, there are tools. There's the Focus tool that's currently online. There's a number of independently developed AUC tools. But you're right, we need to do this better, and we need to have it integrated into our workflow. We all are too busy. We don't need to spend extra time referencing things. It has to be when you order the test.
If you can identify yourself, that would be great.
Absolutely. I'm Dr. Qureshi. I'm a community cardiologist, and I could not help, but please, if you give me a few seconds to explain myself. In this era of defensive medicine, like Dr. Williams touched upon, in this era of using clinical judgment, in this era of appropriate use criteria and providing better patient care and regulations and appropriate use and, of course, making patients happy. With all due respect, I apologize, but we have this audacity. We keep blaming physicians for the way we practice medicine. We keep giving examples of these one or two cases, and if you believe in evidence-based medicine like I do, these are outliers. We would not even be thinking about them if this was a statistical study or model. But we keep using those cases to define the rest of us who practice good medicine. We are a cardiologist seeing 20, 30 patients a day. Medicine is a dynamic field. Every patient is different, like you said. I used my best clinical judgment in day-to-day practice. But to be very honest with you, to blame us for not doing that once or doing one extra study that was an outlier and using my whole career for that one study is not fair. And to be very honest with you, I asked this question from Dr. Braunwald also. You're the academicians. You are the ones who come up with the appropriate use criteria. I believe that you should come up with a protective environment for us in today's date where the tort reform should be pushed. I mean, you mentioned that each case is different. I agree with that. But where are you when I need protection? So,
Thank you for your sentiments from the heart. Dr. Williams, what's the college doing?
So I can tell you that not just the college, but the American Medical Association, we have all been fighting. And you can imagine how fragmented, this presidential race is. For years, this has been a fragmented and divisive Congress. And you can get some traction in some portion of the House and some portion of the Senate, and it never really gets done. The only way to get this is to do it state by state. We had President Obama come to the AMA and address the House of Delegates in 2009. And it was one of the principles that he spoke about is indemnifying physicians for following good clinical practice guidelines. Everybody stood up and cheered, and where's it gone? And so we need to have this is a good opportunity to talk about involvement, advocacy, join your PAC, join your state organizations, and let's get this done on a national level. This is not town versus gown. This is not, because this happens in academia as well. I run a large academic clinical practice at Rush, and we have the same issues going on as you do in private practice. And so we need to band together, and we need to make sure that this happens in the next Congress or two.
I completely agree with you. We should not be defined by an isolated case or one particular circumstance. And unfortunately, some of the regulators and especially the payers are trying to do just that. And they're trying to say if it's in that category, you shouldn't do it, period. And, there has to be flexibility. And that is actually very clearly stated in these collegial developmented AUCs that were developed by us, for us, to prevent an outside force for doing this. And I think the only way that we can start to look at this is as a community. I'll give you one example. The American College of Cardiology has been running a statewide substitution of RBMs in the state of Delaware now for ongoing 3 years. We saw patterns. Most of the practitioners were doing an outstanding job with very low rates of rarely appropriate tests that were ordered. There were a couple, though, that were really bad and were skewing the results because one gentleman had 75% rarely appropriate studies in his practice, clearly doing not even annual exams, sometimes twice-a-year exams, no indications. So what do we have to do? We have to also step up ourselves to look at this and say, look, you're ruining it for everyone else. So the governor of the ACC in Delaware and myself and others had a series of phone calls to some of these outliers, as you point out. We tried to encourage them and reasons why and that the future, and the answers were horrible. One is like, well, I'm retiring in 2 years. I got to get the last brass ring. I mean, you know, that makes us all look bad. So we do have a responsibility to have some ownership to this, and we try to construct it so that we should have flexibility for good practice like you're describing, and it shouldn't be hard and fast. But unfortunately, all it takes are those cases like we heard today to give an impression that we as an entity are overdoing it and are usury and are doing the wrong things. And I think that's why the AUC were developed, to try to help bring people into a domain that's not excessive as the cases that were described. So I agree with you that, you know, we should be allowed to have good clinical judgment based on evidence, and even sometimes when the evidence is supportive, we to have some flexibility, but I think there are extremes to that behavior.
I completely agree, and thank you so much for such detailed responses. I am from Delaware, actually, and I was part of that original beginning of that process where the insurance companies were not allowing us to do the cases, and there were 2 deaths. And then we had to push for it, and we started that process where pre-authorizations were inappropriately rejected, basically. So thank you so much. But to be very honest with you, I would encourage our academicians to get more in touch with community cardiologists. They should try to fill that gap there, because there is definitely a disconnect. On the academician side, you think that all we do is testing all day and we're sending our kids to college, which is partly true, but and secondly, I think we should try to where we we glamorize all these studies. I'm also very well published in Circulation and JACC, but I think what the community cardiologists are doing is also praiseworthy, and you guys should try to bring it to light that what good work we are doing. We are reducing mortality, we are saving lives, we are helping patients with taking their medications. So I think all things should matter.
So Dr. Stowers.
I'd just like to state that in New Zealand there is no malpractice insurance because they're mitigated by a national board of specialists and laypersons that determine the degree of injury and the financial compensation, and there's no litigation. And New Zealand spends a few $1 million a year on medical injury reimbursement, while the United States spends hundreds of billions of dollars. But in the end, the percentage of New Zealanders who have been victims of medical error are 5.6%. In the United States, it's 9.7%. So for these billions of dollars that we're spending on litigious recovery of medical injury, we're really not reducing the number of medical injuries in the United States.
Sobering thought. Any other comment from the audience? Okay, so why don't we move on to the second case, talking about reducing radiation in the real world. We take your comments very seriously, and that's why we have representation, not just from the ivory tower of academia here, but from people in the trenches who are ultimately, most of the burden of cardiovascular disease reduction undoubtedly comes from you community cardiologists.